So let's go ahead and get started. We're going to be talking today about the sleep issues related to myotonic dystrophy. So just a quick review. We're just going to talk about some of the more common sleep disorders in the general population, and then we'll emphasize some of the ones that occur more commonly in myotonic dystrophy, such as the CNS hypersomnia, restless leg syndrome, and sleep apnea. We'll first kind of focus on some symptoms such as the excessive daytime sleepiness, and then we'll talk about some healthy sleep habits, and then go on to some particular disorders in myotonic dystrophy. Also, I do want to spend a little bit of time just talking about what to expect during a sleep study if you haven't already undergone a sleep study. So just a quick review. I updated this maybe 15-20 minutes ago, actually, and this number right here grew by 1 overnight. So this is the number of articles on myotonic dystrophy. Quite a bit of research has been done on myotonic dystrophy, but when you do a similar search and add sleep, the number drops quite significantly to only 130. So what does this mean? Basically, the message is quite clear. More research is most certainly needed in the arena of sleep medicine as it pertains to myotonic dystrophy. So before we delve into any particulars, I just want to give a general overview of sleep disorders. There's probably many people on this webinar, and probably even more physicians in the community and across the states that don't even know that that there is a specialty called sleep medicine. So I just want to give you an idea of the types of sleep disorders that we deal with in sleep medicine. And maybe perhaps you have one of these, and maybe you would benefit from seeing a sleep specialist. So by far one of the more prevalent disorders is insomnia, and we see our fair share of that in the sleep clinics. And then probably a second to that would be sleep apnea, sleep-related breathing disorders. Hypersomnia is of central origin, like Leslie said. That's one of my areas of interest. I do see a fair number of narcoleptics and patients with idiopathic hypersomnia, and we'll touch upon that in this talk. Circadian rhythm disorders, people that they would like to go to bed earlier, but their body doesn't allow them to fall asleep until 2 or 3 in the morning, and then they sleep all day. That's one example of a circadian rhythm disorder. And then there's also the exact opposite of that, such as advanced sleep disorder, where people go to bed exceptionally early and then wake up exceptionally early. But that's circadian rhythm disorders. Parasomnia is an interesting type of disorder. The word parasomnia, basically it means any kind of abnormal activity that's coming out of sleep. So acting out your dreams, sleepwalking, sleep tears, those are kinds of examples of parasomnias. And then sleep-related movement disorders we'll touch upon, but examples might include kicking while you're asleep, a disorder known as periodic limb movements, and things of that nature. So that's just a general overview. So if any of those touched on maybe a disorder that you might have, you might want to go see a sleep specialist. So if everyone can grab a pen and paper, I just want to do a quick evaluation of how sleepy you are right now. And so this is going to be the Epworth sleepiness scale. And if you can just read this with me, basically it's going to assess a variety of different situations and how sleepy you are in recent times if you found yourself in those situations. The scale is 0. So there's going to be a series of 8 different situations, and with each situation that I show, you're going to either say 0 would be no chance of falling asleep, 1 would be a slight chance of falling asleep, 2 moderate, and 3 a high chance. So let's go. Hopefully everyone has their pen and paper in hand. So sitting and reading, how likely are you to fall asleep, right? Just put a number there, 0, 1, 2, 3, and we're going to add up the total score in a bit. Watching TV, and this is in recent times, and if you haven't been in any of these situations in recent times, you can let your mind be a little creative and just think, if you were to find yourself in that situation, how would you behave? Sitting inactive in a public place, such as a theater, a meeting, a passenger in a car for an hour without a break, Lying down to rest in the afternoon when circumstances permit. That should always be permitted. Sitting and talking to someone. You'd be surprised, and I'd be curious to see if there's anyone out there that has actually fallen asleep mid-conversation during a conversation that they were enjoying. But I do hear this. Sitting quietly after a lunch without alcohol. And lastly, in a car while stopped for a few minutes in traffic. And so now just take a second and just add up your total score. A score on the Epworth sleepiness scale, a score greater than or equal to 10 is often considered excessively sleepy. Some actually will refer to it as 11, but greater than 10 is in general considered excessively sleepy in the general population. So this is a very important point that I encounter on a daily basis. Clinically, even when I'm face-to-face with a patient and caregivers, it can be quite challenging for patients and healthcare providers just to differentiate the sleepiness from fatigue. Sleepiness is this true tendency to fall asleep, whereas fatigue is a feeling of exhausted, lack of energy, I can't go on, that sort of thing. And even in spite of me explaining these differences and subtleties between these two, patients still oftentimes can have difficulty differentiating them. And even more so is that, one second, sorry. Yeah, so the Epworth sleepiness scale is definitely the most widely used sleepiness scale. So you just took the most widely used sleepiness scale in the States. But there's definitely talk that it might not be the best scale to characterize sleepiness in myotonic dystrophy. Myotonic dystrophy patients, they definitely endorse quite a bit of fatigue as well. And like I said, that can be challenging to differentiate. So let's talk a bit about sleepiness in myotonic dystrophy. It has been reported to be one of the earliest symptoms in some patients. Over 80% of patients may actually report some sleepiness or impaired sleep. And I've definitely encountered this quite a bit where patients with myotonic dystrophy, they really deny any symptoms of sleepiness. But then when I start interviewing a family member, the mother, the father, they emphatically emphasize how sleepy they are. So there's clearly a little bit of a disconnect or unawareness of sleepiness in myotonic dystrophy patients. The sleepiness undoubtedly does impact quality of life. There's no question about that I've witnessed. And just one countermeasure, we frequently use or call upon when we're sleepy is a nap. And naps, in some they can be restorative, but as a general statement, naps are often not restorative in myotonic dystrophy. So I just want to touch on some healthy sleep habits that everyone, including myotonic dystrophy patients, should try to incorporate into their daily life. Then, like I said, we'll focus our attention on some particular sleep disorders in myotonic dystrophy. So healthy sleep habits, here we go. So Zycobers, I absolutely love this word. I hope you also become equally interested in this or like this word as well. So a Zycober is an environmental cue that synchronizes the internal clock to the Earth's 24-hour light and dark cycle. One example that most everyone is aware of is when we travel frequently via plane and we go across several time zones. You immediately become aware that, my goodness, my body is not in sync with what the day and night cycle, and so that we often refer to that as jet lag. But so clearly, if you think about traveling in the past, there's something in our environment that cues our own body as to what time it is, and if that's out of sync, we don't feel that great, and it can be a struggle to get through the day. So it's clearly, based on that example of jet lag, it's clearly important to maintain regular Zycobers to facilitate a healthy sleep and wake schedule. So let's talk about some of what Zycobers are, some specific examples. So light is by far the most important and well-researched, I think, Zycober to help regulate our sleep and wake patterns, and we'll talk more about that in a second. Exercise, if you stop and think about it, our body is looking for any cues to let us know what time of day it is. And so if you exercise at a normal time every day, say it's in the morning, that's a cue for your body as to where you are in the day-dark cycle. Social interactions. If any of you have ever, gone out one night and stayed out past your bedtime, when you finally get back to bed, it might feel great, but you might notice you have a little bit of trouble falling asleep. So social interactions definitely can impact our sleep-wake schedule. And then eating and drinking, probably very important as well. But of those four, light is so key. So let's talk about what we need to do with light. And really, my example, the teaching point is quite simple. Just respect light. So, and do what you probably know that you should be doing. Kind of dim the lights in the evening and obtain adequate light in the morning. Think about before the advent of electricity and lights, and even when we were living out on the range and whatnot, we were at the mercy of the sun. And when the sun went down, we had a campfire, but largely we didn't have artificial light to do what we want, or a laptop here and there that we could just stay up into the wee hours of the night. So in general, the recommendation: dim the lights in the evening and obtain adequate light in the morning. Now, I can recommend that, but I want to just touch on the science behind this recommendation. There is a wealth of literature to support this recommendation, particularly if anyone has a circadian rhythm disorder like delayed sleep, where they can't get to bed until 2 or 3 in the morning and then they sleep half the day. This can really help. So light enters our eye. There's a beautiful sunset. It looks a little granulated on this, but I apologize. But it was a beautiful sunset in Hawaii. And it enters our eye, and then it travels to a part of our brain, and this name doesn't matter too much, but I just want you to know we do have it narrowed down to a certain part of the brain, the suprachiasmatic nucleus, which we often call the circadian pacemaker. And then it travels onward to the pineal gland, and I know most of you probably have heard of melatonin, and we actually make melatonin. Our pineal gland makes melatonin for us. And just to talk a little bit more about melatonin, we endogenously, we release physiologic levels of melatonin if we don't have any circadian rhythm abnormalities about 2 hours before our habitual sleep onset. And light can definitely impact this. So just in summary, there is a complex interaction between light and melatonin that influences the sleep-wake schedule. Again, the overriding message here is dim the lights in the evening and obtain adequate light in the morning. So one thing that's quite interesting, or a question that I would pose to you all, this won't be an audience poll, but has light, electricity, and technology and societal pressures impacted sleep? And just ponder that for a second, right? Getting up in the middle of the night, unable to sleep, we can turn to our laptop, the TV. Recall the days when TV shows weren't on in the late at night. There's all kinds of things that can occupy our time 24/7. So it's not shocking to hear or to learn that self-reported sleep duration has declined by almost an hour or two over the last century. And there's a whole host of research going into the implications of this. For example, while over maybe the last century, self-reported sleep duration has decreased, what has increased as a population? Obesity has increased. And so we start to play this chicken or the egg question. Which is there a cause and effect here? Which one's causing which? And that kind of thing. But it's not surprising that self-reported sleep duration has declined by the last 1 to 2 hours, or by 1 to 2 hours of the last century. What will be interesting as we move forward is with this advent and almost fascination with quantifiable metrics, all of these actigraphy watches and stuff that are coming out. When we actually start objectively monitoring sleep duration, what we learn about this. So let's talk about regular exercise. So I think everyone out there knows that we should exercise on a regular basis. And typically, I think if you stop and think, so how does exercise and sleep interact? Most will say, oh, well, if I exercise, it will lead to better sleep. And that data exists. But emerging data in the last few years, and maybe before, but a couple articles that I'm thinking of in the last few years, suggests that a good night of sleep may set you up or may lead to more exercise the following day. And I know for myself, if I look back and think about it, that actually rings true for me. If I get a good night of sleep, I'm more likely to say, wow, I feel good, I'm going to go exercise the next day. So it can start a vicious cycle, or it could be a fantastic cycle. A good night of sleep leads to exercise, then you sleep better, then you're more likely to exercise the following day, et cetera, et cetera. But it's an interesting way of looking at the interaction between exercise and sleep. One thing that I often get asked about is define the best time during the day to exercise for good sleep and healthy sleep and whatnot. And I think the first answer to this question that's posed to me often is well, exercise when you're most likely to do it. So if you're most likely to exercise if in the morning is when you feel best and when you're most likely to exercise, then do it in the morning. I think in the next 100 years, we might have very sophisticated ways to say when the best time based on your circadian rhythm you should be exercising, the best time that you should be taking a test, the best time that you should be playing a sport, etc. But I don't think we're quite there yet on an individual basis. So the best time is the time that you're most likely to do it. And most certainly in patients with myotonic dystrophy, given the cardiac abnormalities and arrhythmias, I'm just giving a general recommendation that everyone should be exercising, and it will lead to better sleep, perhaps. But definitely review this, your exercise program with your physicians, your local physicians. So social interactions. So in general, the message is to maintain social events within your normal sleep and wake schedule. So what is the optimal amount of sleep? When you ask this question, what's the optimal amount for you? In general, data suggests 7 to 8 hours, and on this poll, 41% of you were sleeping 6 to 7 hours, whereas the 7 to 9 hour window, only about 6% fell into within this suggested duration of sleep. It does definitely vary from person to person. I think the most recent data for short sleepers, there was 18% less than 6 hours. I think the most recent data on short sleepers was somewhere around 10% or something like that in the population, and somewhere similar like that for long sleepers as well. Maybe around 8% are actually long sleepers, more than 10 hours or so per day. But it definitely varies from person to person. And myotonic dystrophy patients, it is reported to have long sleep times, and that kind of fits this poll. About 12% of you reported sleeping longer than 11 hours. Perhaps maybe I should have created another option there to really see who's the longest sleeper out there right now. So this is another one of those frequently asked questions that I get. How many hours of night should I be getting? Well, the simple answer here, and I always turn the question back on the patient, is, well, what's the optimal duration that makes you feel well rested? And that's the number that you should be striving for. Now, if you can never define that number, then maybe that's when you need to see a sleep specialist and talk to your physicians, your local physicians. But there's a lot of evidence to suggest that if you're not obtaining your optimal amount of sleep, then you are most certainly at risk for something, a nice fancy word here called chronic partial sleep deprivation, basically not getting enough sleep on a chronic basis, which may lead to all sorts of changes such as mood, cognition, memory, attention, concentration, alertness. So again, the message probably here is define the optimal amount of sleep you need and strive to obtain that amount. And then once you kind of define the optimal amount of sleep, right, we want to get that sleep within a regular sleep and wake schedule. So again, this is probably stuff that everyone knows in the audience, but everyone should probably hear from time to time. As a reminder, go to bed at a consistent time each night. Wake up at a consistent time each morning. If I had to pick which one's more important, I would say wake up at a consistent time each morning. If a nap is needed, try to limit it to around 20 minutes or so. What happens when we take longer naps than that, we start to get in the deeper stages of sleep, stage 3, stage 4. These are the stages of sleep where as a child and even as adults, we release a lot of growth hormone. But what happens is that when you try to wake up from those deep stages of sleep, you have this incredible amount of sleep inertia. And so when you sleep for 45 minutes, an hour, 2 hours, you wake up out of that deep sleep and you're just so groggy, and the nap is just not nearly as restorative. And more importantly, the more you sleep during the day, it's going to impact your ability and how well you sleep at night. So oftentimes you don't want to be short-sighted in what you're doing as far as your sleep and wake schedule, right? Long term, keep those naps short so then you have better sleep at night. So let's just touch upon, we just touched upon it, but just to show you a nice picture of normal sleep architecture. So in general, when we go to sleep or when we first take a nap, we go into a light stage of sleep, and during the night, the whole night of sleep, we get a lot of deep sleep in the first half of the night. This is when growing up, a lot of us maybe have experienced some sleepwalking or sleep tears, or doing odd things, confusional arousals in the first half of the night. Those typically arise out of this deep sleep, slow wave sleep. And then as the night progresses, we get more and more dream sleep. So I don't know if you can see my mouse here, but here, stage 3, 4, those are the deep stages of sleep, okay? And then REM is rapid eye movement, which is dream sleep. And here on the x-axis are the hours in the night. And what you see is a little bit of dream sleep occurring, in the first hour or so after falling asleep, and then it gets longer and longer and more dream sleep, and the deep sleep actually dwindles as the night goes on. So they're inversely related. Lots of deep sleep at the beginning of the night and lots of dream sleep at the end of the night. And everyone is probably aware of this. So recall the last time, maybe you never have, but most people have, recall the last good dream. You woke up and you're like, wow, that was an amazing dream. And then think, what time did that occur at? And in playing the odds, you can see here, it was probably in the morning hours. And so it's completely normal, and most likely that if you wake up from a dream, it's going to be towards the latter half of the night in the early morning hours. So that's in general sleep architecture. And you can see that we go from a light sleep to a deep sleep and then go into dream sleep, and the cycle just kind of repeats itself. Every 90 to 120 minutes, we go from light sleep to dream sleep, light sleep to dream sleep across the night. And it's completely normal. I think if anything I can offer to patients out there or in the people in the audience is that it's okay to wake up a couple times during the night if you don't have too much trouble falling back asleep. That's perfectly normal to have physiologic arousals, normal arousals and awakenings a few times during the night. So let's just touch on one other thing. As far as healthy sleep habits, you definitely want to limit your alcohol consumption throughout the night, close to bedtime. As a sleep doctor, this is a joke, but I just want to send this message, make this message clear. As a sleep doctor, I often joke with my patients that if you're going to choose to drink alcohol, I would rather you do it in the morning. It's less likely to impact your sleep. Now, obviously, I don't want you to get behind the wheel. I don't want you to go to work. I don't want you to go to school. But it's just a message. If you limit alcohol consumption, particularly close to bed, avoid it close to bed. And so just to talk a little bit about the science behind this, because I'm sure you've heard this, and I just want to let you know a little bit of the science. So alcohol consumption clearly alters that sleep architecture that we just reviewed. You get less dream sleep. Your first dream sleep period occurs later in the night. It does actually, ironically enough, increase deep sleep, particularly at higher doses of alcohol, but that's no reason to ingest alcohol because look at the last point, it actually increases the time spent awake across the night. So you end up leading to a more fragmented second half of the night and whatnot. It could worsen sleep apnea, which we'll talk about in a second. And don't forget that alcohol can interact with some of the medications that you take, such as sleeping pills or anything like that, and lead to bad outcomes. So limit the amount of alcohol. And along those same lines, avoid caffeine beverages after lunch. Maybe it's 2 p.m. but as a general message, limit them to, nothing after lunch. Don't have any caffeine if possible. So a little bit of data on that. How does caffeine actually affect our sleep architecture? Well, it's no surprise that it will delay our sleep onset, so we have a little bit more trouble falling asleep. It reduces the total amount of sleep we get. We get less deep sleep. But interestingly, it doesn't really affect dream sleep too much. It could worsen insomnia and other sleep disorders. And then, as far as this is one thing that I'm starting to pay more and more attention to in the clinic. But talk to your physician about when you're taking medications, because there are a host of adverse effects of commonly prescribed medications, which may include insomnia, fatigue, and or sleepiness. And it could be, if a medication that you're taking at night is perhaps contributing to insomnia, wow, or it might be better to take that medicine in the morning because insomnia during the day is quite a good thing, I think. And vice versa. If you're taking a medicine that causes sleepiness, which is or fatigue in the morning, maybe you could take that at night. So have this conversation with your physicians. It's something in a busy clinic, and you're seeing lots of patients, and with healthcare where it is these days, physicians might overlook this simple thing. So broach this topic with your physicians. Yeah, and that's basically what I was saying. Just review the medications with your physicians to ensure optimal dosing times and strategies. So just to touch on the next topic, and this isn't exactly reported to occur a lot in myotonic dystrophy, although up to 70 million Americans may have insomnia. So I thought we would just touch upon it. And there's a couple treatment options that aren't very well known in the lay public or even in the healthcare community, so I wanted to touch upon this briefly. So how do you define insomnia? Well, one thing I talk about in the clinic is that if it takes you 40 minutes, if a patient's telling me it takes them 40 minutes to fall asleep each night, and I ask them, and they don't have a problem with this, it doesn't bother them, it doesn't lead to daytime consequences, they don't get frustrated, they don't have insomnia by definition. However, the next patient I see, they could say, it takes me 20 minutes to fall asleep, and it creates so much stress for me and anxiety, and I can't sleep, I can't function the next day. So it's on a case-by-case basis, and it's really the person's perception of their sleep. So if you perceive that you're having difficulty initiating or staying asleep, and it's leading to daytime consequences, and it occurs fairly frequently, you have insomnia. And it's very prevalent. And so some treatment options. So we just touched on some very basic healthy sleep habits that you can institute in your daily lives to help prevent or to minimize the symptoms of insomnia. And we could have a whole lecture on different types of medications, but I just want to mention there are medications out there that are FDA approved for insomnia that you can talk to your physicians about. But this is the main reason I have this slide up here is cognitive behavior therapy for insomnia. We do quite a bit of this at Stanford. We have an excellent behavioral sleep medicine program, and the interest in this type of therapy is growing, and there's a wealth of research coming in to support this. And so what it is you actually meet with a psychologist, someone that's pretty much dedicated their lives to treating people with insomnia or circadian rhythm disorders. And it would be a whole talk in and of itself, but they'll teach you about stimulus control, strengthening that association with bed and sleep. There's only a few things we should be doing in bed, but in general we shouldn't be laying in bed for hours on end, resting or watching TV. Sleep consolidation. What's so interesting, and I'll just touch on this briefly, is the natural reaction, and I see this time and time again with patients with insomnia, is they struggle to get that magic number of hours of sleep. Maybe it's 6 or 7. They start getting insomnia, and then they're only getting 4 hours. Well, what is the natural reaction of this? Well, I need to spend more time in bed to get to that 4, 5, 6, 7, 8 hour, that magical number. What does that do for insomnia? Well, again, remember I said it's a perception of how you're sleeping. If you still are getting that same number of hours of sleep, or maybe a little bit more, but spending a heck of a lot more time in bed, the perception of your insomnia is it's worse. And so they'll teach you some concepts in sleep consolidation, relaxation therapy, sleep hygiene, and cognitive therapy, but definitely talk to your physician if there's significant insomnia at hand and you've tried some medications, or maybe you don't want to do medications, which I fully support. Definitely entertain the idea of a referral to a cognitive behavior therapist. So, without further ado, let's review some of the sleep disorders and our findings in myotonic dystrophy. And so these are the things we're going to go over in the last half of this talk here. So we touched on what normal sleep architecture was, right? Lots of deep sleep towards the beginning of the night and more dream sleep towards the end of the night, right? Well, it turns out in myotonic dystrophy patients, based upon the limited amount of sleep, overnight sleep study data, sleep studies, research with sleep studies that we have, that they have more short microarousals. These are short awakenings in the brain that maybe last for 3 seconds. You know, we might not be cognizant of these, meaning that you don't have, you wake up for 3 seconds and you might not have any recollection of actually waking up. And so you could have these throughout the night and wake up feeling like you slept soundly all night, didn't have a single awakening, but just not feel well rested. And that could be because you're having a lot of frequent arousals during the night. Interestingly, in some studies, they've actually shown that you have more deep sleep, more dream sleep, and about the dream sleep, the REM sleep, rapid eye movement sleep, that's when we dream, might even have more muscle activity during REM sleep compared to controls. And so let's, oh, and then this is one thing. So in this, in the audience here, right, 56% of you reported being excessively sleepy, and 44% of you said you're not excessively sleepy. So if we actually do sleep studies on everyone on this call here, what we would find is that some of you would have some of these findings of microarousals and slow wave sleep, but at the end of the day, based on how we currently look at these sleep studies, it would, in the brain waves and everything, we could not distinguish based on the sleep studies which ones are reporting subjective sleepiness on that Epworth sleepiness scale. So sleep study findings do not help explain differences between those with and without sleepiness. So it's REM behavior disorder, or REM behavior disorder, RBD. So normally when we dream, this is so fascinating to me, we're paralyzed. And when you stop and think, oh, why would evolutionary speaking, why would I want my body to inhibit muscle movement when I'm dreaming? Well, it makes sense. You're dreaming of running down the street in the middle of the day. That wouldn't be great as far as survival of the fittest. So we're actually normally we do not have any muscle activity, inhibition of muscle activity during dream sleep. So if significant muscle activity on a sleep test is observed while someone's dreaming, think of it as a lot of muscle twitches occurring on the sleep study, and then by history, that patient or person reports this thing we refer to as dream enactment behavior. Basically, that you've hurt yourself or someone in bed at night, and then maybe that person or maybe you wake yourself up, and you have this recollection of, oh, there was someone attacking me, and I was fighting them off of me, or there was a lion fighting me off of me. That's this entity that I'm trying to describe, dream enactment behavior. Then we should then a diagnosis of REM behavior disorder should be considered. Now, one caveat: I'm not saying so that we should consider REM behavior disorder. So myotonic dystrophy patients, clearly there's some evidence to suggest that they have increased muscle activity during REM sleep. And remember, in normal sleep, REM sleep, dream sleep, we should be paralyzed. And I am only aware of really one case report to date of REM behavior disorder in myotonic dystrophy, and that was actually in type 2. And there's a recent publication that just came out in type 2 myotonic dystrophy patients, and they didn't find any evidence of REM behavior disorder as well. But there is clearly this increased muscle activity during dream sleep. And so this is interesting, and it's quite interesting that 16% of you reported an injury during sleep or to a bed partner. So maybe this is in fact occurring out there. So definitely more research is needed on this area. But in general, the literature to support that RBD occurs frequently in myotonic dystrophy is quite limited. But we need to keep an open mind at this point, since it's early in the game as far as research and sleep and myotonic dystrophy. So let's switch gears. There was a lot of questions as people were registering for this on sleep-related breathing disorders. So by far the most common sleep-related breathing disorder is obstructive sleep apnea. Other types of disorders are central sleep apnea. That's the way I explain this to patients is central sleep apnea is kind of when the brain forgets to tell the diaphragm to move up and down, or the brainstem forgets to tell the diaphragm to move up and down. Hypoventilation is think of it just as kind of shallow breathing, and given some of the respiratory findings and weakness in myotonic dystrophy, when you fall asleep at night and sleeping on your back, you might tend to hypoventilate, breathe shallowly throughout the night. And let's just touch on some of the symptoms, signs and symptoms of obstructive sleep apnea. There's a whole host of signs and symptoms ranging from snoring, witness apnea, dreaming of gasping and choking, dreaming of being underwater, but gasping and choking, unrefreshing sleep, daytime issues, frequent naps, dry mouth to mouth breathing, sweating at night. This is one that I always, when I get a patient that's endorsing this, I definitely pause and investigate a little bit further. There's some other causes of sweating at night, but when the sweating is out of proportion to the ambient temperature, there's only a few instances when we sweat. When you're giving a talk in front of an audience, when you're anxious, nervous, when you're working out and exercising. So if you're sweating at night, that I don't think we're anxious when we sleep. We're actually sleeping. So if you wake up out of sleep sweating, it might suggest that you're working hard to breathe during the night. And so don't overlook that as a symptom of potentially sleep-related breathing disorders. And then waking up with headaches. That can often be a sign of sleep apnea and other breathing disorders at night. There's some data suggesting, actually, one article in particular, it was in type 2 myotonic dystrophy, but there's a publication stating that 67% of the population in this cohort exhibited sleep apnea. So in the general population, a diagnosis of at least mild sleep apnea is about 25% in men and about 10% in women. And then in a recent study, this is just talking about severe obstructive sleep apnea. Severe is when you stop breathing, say, 30 or more times during the hour. It was about 28% in myotonic dystrophy versus about 8% in controls. And so severe sleep apnea, this is if you've been told that you have severe obstructive sleep apnea, in patients without myotonic dystrophy, this has been shown to increase your cardiovascular risk of heart attack and stroke. And I'm not telling you this to scare you, but it's something that you should definitely take serious, especially given what we know about myotonic dystrophy and the cardiac abnormalities and conduction abnormalities. So definitely take a serious note of this number here. And if you've been diagnosed with severe sleep apnea, really try to work with a sleep doctor that can try to make that machine or whatnot as comfortable for you as possible. And so on that note, I just want, for those 37% of you out there, the caregivers included, that have never had that sleep study, what to expect during a sleep study. I think there's a lot of people out there that never undergo a sleep test just because they're scared, or they don't, the unexpected, oh my gosh, you're going to make me sleep in some bedroom or hotel room like for the night. And so I think there's a lot of people that were missing just because they're nervous. So what we see here is we monitor the breathing with a little nasal cannula, nothing more than an oxygen cannula, basically nasal cannula, to monitor the breathing through the nose and out of the mouth. And then we put some belts around the chest and abdomen to monitor breathing effort. Okay, and then you see a whole variety of electrodes on the forehead and the head. We're monitoring the different sleep stages with those. And then the eye electrodes right around the eyes. quite fascinating. These electrodes are what tell us when someone's dreaming, or help to tell us when someone's dreaming. Monitor your oxygen content, and then we also monitor for leg movements. It has been shown that leg movements might occur more frequently in myotonic dystrophy patients than controls. So that's the 2-second version of what to expect on the night of your sleep study. And then this is just a quick snapshot. I just want to show you the wealth of data that we obtain from a sleep study. And this happens to be just a 5-minute example of from here to here is just 5 minutes of someone with very significant obstructive sleep apnea. And you can see that they're, without going through all of these, I'll just you have to take my word for it. The airway is completely closed here, partially closed here. The oxygen is going up and down. You see right here. On this, it dropped to a low of 82%. And so in this individual, they had a total of what, 1, 2, 3, 4, 5, 6, 7, 8. 8 obstructive events or closures in the airway in 5 minutes. And so if you did the math, that would be this person would end up with an AHI of 90, and AHI is an apnea-hypopnea index. It's the term we use to characterize how severe someone's sleep apnea is. They would end up with a number of 90 times per hour their airway is closing. And remember, with severe sleep apnea, it's more than 30 by definition. So that's just a quick snapshot of a sleep study. So here I just want to show you what sleep apnea is. And this person is laying on his back. And what sleep apnea is really just a collapse of the tongue in the airway, just posterior to the lower jaw. And what CPAP, so CPAP is one of the more common treatments. All it is, I like to tell patients, is it's a glorified medical grade air compressor. It just takes room air, it's not oxygen, and pressurizes it, and it keeps this tissue open. It keeps the tongue prevents the tongue from collapsing backwards, and so that you can continue to breathe normally. It is not oxygen. And then there's some other treatment options that I just want to point out. If you've tried, CPAP or bi-level or one of these positive pressure, devices where you have to wear a mask, there are other treatment options such as an oral appliance. Weight loss can help. Avoiding your back. So if for the adults out there, in general, when it comes to sleep disorder breathing, we should try to avoid our backs. What happens when we're on our backs is that gravity works against our airway and our tongue, and it can actually worsen sleep apnea or make it more likely that the tongue actually falls back into the airway here. And so staying off your back in general, and I'm sure there's plenty of guilty people out there sleeping with a bed partner that have gotten the elbow in the side of get over to your side, you're snoring again. And so that, I can't emphasize enough that person is telling the truth. They've witnessed you snoring more on your back, and when you go to your side, it's much less. And the same thing holds true for sleep apnea. On your side, it can be better. And then there's plenty of surgeons out there that are willing to open up that space back here with some surgery as well. Definitely, of these treatment options, I would definitely start with the CPAP and stuff like that. So here are just 3 different manufacturers of different types of CPAP machines. They're quite small. They go right on the nightstand, very small, and they're getting better and better as far as their appearance. This one almost looks like an alarm clock. Actually, I think it does have a clock on it. But CPAP stands for continuous positive airway pressure, just medical grade air compressor, basically. Now, given the GI symptoms, I think that you've had a webinar on that in myotonic dystrophy. I just want to emphasize that there are 2 common side effects, or one common side effect in particular from CPAP, is aerophagia. And what this is, and I just want to go back real quick. You can see that the positive, when we have this mask on our face, which I'll show you in a second, it's blowing pressure to keep this open. Well, some of that pressure that we're administering can go into the stomach, and that can lead to bloating, gas, belching, flatulence. And so pay attention to this. If you notice that these symptoms have worsened all of a sudden, it could be the positive pressure of the CPAP machine or whatnot causing it. And of course, we're blowing all this pressure into the airway. You can wake up, it's not infrequent that patients say, complain of dry mouth while wearing one of these devices. So this is another thing that often gets overlooked as far as compliance and tolerance of the machine. So there's different mask options out there. This is a nasal pillow mask option. There's also nasal triangular masks that go around the nose. And then there's also a full face mask that goes around the nose and the mouth. If you've tried a machine in the past and you only tried one of these particular masks, probably most likely that the DME company gave you a full face mask, definitely circle back with your sleep physician or prescriber of the machine and see if you could try it again with one of these other mask interfaces. There's a wealth of data, or some data at least, to support that mask selection is key to tolerance and compliance with these positive pressure devices. And other accessories include, heated humidifiers and chin straps. But given limited time, I'm going to skip over a discussion about that. So there are more. So CPAP is a very basic type of device. There are more sophisticated types of positive pressure devices like bilevel. So if you or a caregiver knows of someone with myotonic dystrophy that have significant on the the blow test, the pulmonary function test, that they've seen a lot of restrictive disease, progression of the respiratory muscle weakness, you might benefit from bilevel. One common complaint I hear with patients on CPAP is that they feel like they're getting smothered when they try to exhale, that the pressures is blowing at them. And so in those instances, maybe switching to something called bilevel, which administers a higher pressure when you inhale, and then when you exhale, it drops the pressure. That can sometimes help tolerate it. And then there's even more complicated devices, which we won't go into, but I just wanted to put that up there. There's very sophisticated devices out there now these days. As far as compliance, if we look at a year out, 1 to 2 years out, if I prescribe a machine to 100 patients, this is not in myotonic dystrophy, 100 patients, about 50 of them will be using it a year or two out. So there's been some growing amount of evidence that there's increased prevalence of restless leg in the myotonic dystrophy population. So what is it? So RLS, restless leg, is an urge to move the limbs, move the legs, and typically it's described as associated with this odd sensation, such as worms underneath the skin or tingling-like sensation. It is not painful. That's one in myotonic dystrophy patients that we need to make that distinction. There's no pain associated with this sensation. It's just an odd sensation. And it's typically worse in the evening when you get into bed or with rest, such as in a movie theater or a long car ride. The urge to move, once you move, it actually is relieved. So if this sensation gets so bad, patients will get up and walk it off at night. And then they get back in bed and it starts back up, and there starts a vicious cycle. And like I said, it's worse in the evening. So just really quick, Leslie, is it okay if I go over just a bit?
It's fine with me, and if people need to leave, they know how to sign out.
And they can always ask you questions, and I'm happy to answer them, after the fact.
Oh, thank you.
So who in the audience, after that very brief description, I just want to go back, urge to move, an odd sensation in the legs, worse in the evening, maybe a long car ride, relieved with movement. Who in the audience thinks that they may suffer from restless legs?
Okay, let's see. I'm going to close the poll. And 35% said yes, 53% said no, and 12% are unsure.
Interesting. So in the patients that I've seen with restless legs, I really haven't encountered this. And so I was actually a bit skeptical of the data reporting this. But it has been replicated to some extent, so I have to believe it. I haven't encountered it yet. So in the general population, restless legs occurs maybe in about 5 to 10% in the general population. Times when it can really increase, pregnancy. In pregnancy, it can increase to 25%. And so it would be interesting in myotonics that during pregnancy how bad this gets. But in a recent publication, RLS occurred in about 22% or so of myotonic dystrophy patients, and so it's clearly increased compared to the general population. So given that what was it, 35% of you in the audience endorse this symptom, I think that we should just touch on some very basic treatment options. One very basic treatment option is if you've ever been diagnosed with a low iron deficiency. It turns out that this is a very common cause of restless legs, or it can exacerbate restless legs. So if that's the case, then maybe this is just one more reason why you should be more compliant with those iron pills and follow up with your primary care on this. Massage and warm bath has been reported to help with restless leg syndrome. A warm hot bath can do wonders for restless legs, particularly when you think about it. The symptoms typically get worse at night when you get into bed. A warm hot bath at night can really help to separate your daytime activities from, all right, it's time to go to bed. And then as a bonus, in patients with restless legs, it can actually minimize the symptoms of restless legs. Alcohol and caffeine maybe can worsen it, but I really haven't seen this pan out by and large. In some, they definitely notice that the alcohol can make it worse, but this is probably one of those 50-50. But it's something you should definitely reflect upon and see if it's exacerbating your symptoms. Certain medications, one of the medications can actually worsen restless legs, such as Benadryl, over-the-counter Benadryl, or diphenhydramine, the generic name. Antidepressants can also do it. And there's a whole host that we don't have time to go into of treatment options for restless legs. But if you, of those 37% or 35% out there that said yes to this, you should really discuss this with your doctor and perhaps a sleep specialist, because this syndrome disease has not gotten as much as attention as it should, and there's not too many physicians across the states that are really comfortable and familiar with this. So perhaps you should talk to a sleep specialist if you have this, especially if it's causing insomnia, right? If you every time you get into bed at night, you get this weird, funny feeling in your legs that drives you crazy, that you end up having to get up and walk it off. Could potentially cause bad insomnia. So just by treating the restless legs, you treat that and the insomnia. PLMs, this is just kicking during the night. So periodic limb movements. Patients might not note this, but bed partners most certainly might report, yes, my loved one with myotonic dystrophy, they kick all night long, and it doesn't bother them, but it bothers me so much that I'm in a different room now. Interestingly, people that have PLM, or people with restless legs, tend to kick more frequently. So we didn't make this a poll question, but of those 35% that said yes to that they think they might have restless legs, I bet a number of them would have also reported or endorsed this, or a bed partner would have said yes, they kick a lot during the sleep. It does turn out that if you treat the restless legs, that the PLMs can actually get better. And this is a leg movement that occurs when they're asleep, not during wakefulness. Okay, whereas restless legs is a symptom or sensation that occurs when you're awake. Clinical significance of PLMs is unclear, and treatment is frankly a little controversial at this point. We don't know quite what to make of PLMs at this point in the sleep field, but there's some interesting findings, that might be very relevant in myotonic dystrophy, such as people that kick a lot. There's been some studies on blood pressure and heart rate, and you actually see an increase in heart rate before these leg movements. You see spikes in the blood pressure. And so in the coming years, we might find that in myotonic dystrophy that have a lot of PLMs, it could be contributing to the cardiovascular outcomes. Now, we don't have any data to support this. I'm just saying stay tuned, basically. If at the end of the day, in spite of healthy sleep habits, in spite of seeing a sleep specialist, and screening you for all of these sleep disorders such as restless legs and sleep apnea, if you're still excessively sleepy, you really need to consider, at least seeing a sleep specialist, because the sleepiness is reported in up to 80% of patients. And just in this audience, 60% were subjectively reporting excessive sleepiness. So 56% of the people should have had maybe a daytime test. What is a daytime test? So the overnight test, it evaluates for sleep apnea, leg kicking during sleep. The daytime test stands for, it's MSLT, a multiple sleep latency test. I kind of describe it to patients as the perfect day. It's a series of 5 daytime naps that's preceded by the overnight sleep test. And so what we look at or what we measure on this MSLT, is how quickly an individual falls asleep across these naps, and whether or not they go into dream sleep, REM sleep. And it turns out that the MSLT data in myotonic dystrophy, anywhere from 12.5 to 44% of the study of the patients with myotonic dystrophy in the studies fall asleep on these daytime naps in less than 8 minutes. Anywhere from, depending upon the study you read, 20% to 60% actually enter dream sleep on 2 or more of the naps. Now, I'm just going to jump into another diagnosis real quick. In narcolepsy, this falling asleep in less than 8 minutes on this daytime test and entering dream sleep on 2 or more naps, that's the very definition of narcolepsy. And so there were some questions of people in the audience of, do I have genuine narcolepsy, someone with myotonic dystrophy that does fall asleep in less than 8 minutes and goes into dream sleep more than 2 times? Do I suffer from narcolepsy? And there's different types of narcolepsy. One type that we have a lot of understanding about is the type that has cataplexy. And you can read about cataplexy on your own, and make sure that you don't have it. I would argue that most of you, if not none of you, have this, based on what I've read about myotonic dystrophy and seen. But it's this abrupt loss in muscle tone that's triggered by emotion, usually laughter. And so if you've ever been laughing and all of a sudden your jaw sags, your knees buckle, you fall to the ground, you feel tongue-tied, and this happens frequently, that's cataplexy. And the data thus far really doesn't suggest that patients with myotonic dystrophy patients have this type of narcolepsy. But just because you don't have that type of narcolepsy doesn't mean that you might not benefit if you do meet this criteria for an alerting medication such as modafinil or some other kind of stimulant as well. So there are definitely similarities on this daytime test between myotonic dystrophy and narcolepsy. I think just because you meet the criteria for narcolepsy, I don't think that you need to walk around saying, oh yes, and I have narcolepsy. I would say that yes, subjectively I feel very sleepy, and when my doctors evaluated me objectively, I was sleepy as well. Is how I would interpret that if you ended up with a positive MSLT. So what are some of the other findings in narcolepsy? The last minute or so. So narcoleptics also endorse very fragmented sleep. Again, we touched on this. Myotonic dystrophy patients can also report this. Sleep paralysis. I wish we had another hour. We could talk about sleep paralysis and see who's in the audience has experienced this, but sleep paralysis is really neat. In that neat, I'm saying it's neat because I never experienced it, but I do want to experience it once, at least one time. But what it is it literally, as you wake up or fall asleep, you try to move, even a finger, and you can't move. Your whole body is paralyzed. Typically, patients will say the first time this happened, it was very, very scary. The second time it happened, scary. And then then if it keeps on going, a couple times a week or a few times a year, they just learn to, oh, I'm having another sleep paralysis attack. What's going on? How do I explain what's going on to patients? Well, it turns out when we dream, like we talked about, we're paralyzed. And so this is essentially dream sleep pervading into wakefulness, which is you're kind of caught in this in-between space between fully awake and dream sleep, and this the brainstem, it inhibits our movement or muscle activity during dream sleep, and this pervades into wakefulness. Along those same lines, sleep-related hallucinations, as you fall asleep, wake up, ever hear things or see things that really aren't there. Those are reported in a lot of narcoleptics, and also the cataplexy, which we already touched upon. Now, one reassuring thing is that the sleep paralysis and the hallucinations, these symptoms can most certainly occur in the general population. And so just because you have these symptoms does not mean that you have narcolepsy. The sleep paralysis and the hallucinations can occur if you're sleep deprived. Oftentimes I'll get a patient that says, oh yeah, back when I was in college or high school or something, I was studying like crazy, or I was working really hard and not getting enough sleep, and I woke up the next day and I had a sleep paralysis attack. And so, yeah, so it can definitely happen in the general population. So what about in myotonic dystrophy? Well, it turns out that really the literature suggests that these symptoms don't really happen any more than in the general population. So again, it seems that the sleepiness in myotonic dystrophy is distinct from narcolepsy. And this could be a whole discussion, but there's a test that we can do to measure hypercretin in the spinal fluid, and it turns out that if you have narcolepsy with cataplexy, you might lack this entity, hypercretin molecule. And so there's been a few studies on this in a few myotonic dystrophy patients, and maybe one or two actually have been shown to be deficient, but I think they're clearly outliers. And in general, myotonic dystrophy patients do not seem to be deficient in this hypercretin. And so there yet again, there's a distinction between narcolepsy and myotonic dystrophy. And so in short, the pathogenesis, the cause of sleepiness, and this propensity to enter dream sleep when on naps is unclear. But even in spite of treating sleep apnea, treating restless legs, healthy sleep habits, myotonic dystrophy patients continue to report excessive daytime sleepiness, or caregivers endorse this. And so it looks like there's this, it's a primary CNS, it's a primary brainstem dysfunction, and further research is clearly needed in this area. And then here, the question as far as alerting agents, yes, there's a number of there's some studies to suggest that myotonic dystrophy patients can benefit from an alerting medication, such as modafinil or other stimulants like Ritalin or Adderall or something like that. But the modafinil is the one that's talked about the most, it seems. But clearly, I'm not telling everyone that's sleepy in the audience to go out and get one of these medications. They may, if you start one of these meds, you need to monitor your heart rate and blood pressure. They can potentially increase that a little bit. And given the cardiac abnormalities and issues that come up in myotonic dystrophy, you have to weigh the risks and benefits of this with your physicians. And this is really my concluding slide before my conclusion, but I just wanted to put this up here, that more research is needed in the role of alerting medications in myotonic dystrophy. And this is a nice publication by Hilton Jones et al. in 2012. And it was basically a survey that they sent out to patients that were on stimulants to see how it was impacting their lives. And I would, if you just read through this on your own time and just see some of these descriptions of how it's impacted their life taking one of these alerting medications. Again, there's studies to support and not support the use of modafinil, that it doesn't make too much of a difference, but definitely have this discussion with your physicians in the area. And so in conclusion, here's my conclusion.
One woman whose son has DM1, she wakes him up after 7 hours of sleep. Should she just let him go till he wakes up? She's afraid that he might sleep up to 12 hours.
So again, this is the question that I get a lot, is what's the optimal duration? Is he sleepy during the daytime? Would be a question I have. If the answer is no, and he's functioning just fine, no other medical issues, or all of his medical issues are well controlled, then it might be okay to wake him up after 7 hours. But the magic number of hours of sleep is in the literature is 7 to 8 hours. So I would say that she probably should try, especially since it's the summertime. I think so. Yeah. Extend that sleep by like an hour. Let him sleep another hour and see how he functions during the day. Is there a benefit? Really try to almost approach this scientifically. I'm going to, for the next 2 weeks, extend his sleep for an hour, and then maybe even 2 hours, maybe even 3 hours, and work with him to define that optimal duration. And if there's sleepiness present, they should be extending the sleep times, most certainly.
The next question: what happens when REM 3 and REM 4, stage 4, are affected?
That's a fabulous question, and so all fabulous questions usually get answered with the thing we don't know. So there's a lot of research. I mean, we can't. What's fascinating about sleep medicine? It's one, it's such a young field, but we can't even answer the question of why we sleep, why we dream, why we go into deep sleep. Now, I could sit here and reference all kinds of articles that support that it's memory, that we sleep so that we can remove toxins that accumulate throughout the day. But yeah, so we don't know. But there are some studies, for example, like if you fragment deep sleep, so stage 3, 4, deep sleep, slow wave sleep, that you can lead to some glucose blood sugar abnormalities, and maybe it can impair memory. And along those same lines, if you fragment dream sleep, that can also affect memory. So there's a growing body of literature to support that sleep is vital for memory. It's kind of, look at it, the current idea out there is that we go through the day being bombarded with all these things. And so we collect all these memories throughout the day. And what sleep does, whether it's the deep sleep or the dream sleep, is that it selectively reinforces those memories that somehow have been deemed important, while prunes out those insignificant memories, so that we go to sleep with more encounters or memories of encounters throughout the day and facts. And when we wake up in the morning, we have lost some of those facts, but the important ones, sleep has reinforced and allowed us to remember those. So that was a long-winded answer, but there you go.
The next question. When using a BiPAP, is there any way to keep the nose clear?
So that might be an instance of mask. So one thing you can do there is really make sure that you have a heated humidifier. If you're taking room air and blowing it into taking room air, pressurizing it and blowing it into the nose or the mouth or the airway all night long, it can tend to irritate things. And so make sure that your humidifier settings are optimized. Turn that heated humidifier up as much as possible with some water in the reservoir, and maybe that will prevent the nasal irritation and dryness. The one side effect I will say is that as you turn up that heated humidifier, is we call it rain out. That's literally rain out, R-A-I-N-O-U-T. That's when water builds up inside the tubing. If that is limiting, if that's occurring, and you're still having the dryness and stuff, they sell insulated tubing now, like sleeves that you can do, almost like a sleeping bag for the tube, that will prevent that water buildup, because it acts as an insulator to prevent the cool air in the room from hitting the warm air inside the tube. Some of the newer machines, they actually have a heated tubing, an element inside the tube that acts as an insulator, and so you can do that. If that fails, then changing up your mask interface, so switching from one of those nasal pillows to a nasal triangular to a full face mask might help as well. Yes. Oh, did I lose you? Hello?
Hi. Okay, we hear you. So
yeah, can you hear me?
Yes.
Oh, yeah. But one last thing. So humidifier, changing the mask, and potentially adjusting the pressure a little bit might be indicated, but that would have to be done with the physician. Okay?
Okay, one more question about BiPAP. Since the high air pressure on my son's BiPAP machine is not helping with his daytime sleepiness and fatigue due to DM1, is it safe to keep him on high pressure since it's not resolving his situation?
So you have to, so again, severe sleep apnea outside of myotonic dystrophy can actually increase the risk of cardiovascular risks, bad things such as heart attack, stroke. So I'd have to see the sleep study and see how severe it is, and does he really need that higher pressure to keep the airway open and his oxygen up. If at a lower pressure he was treating the oxygen, the drops in the oxygen and the brain waking up, or really just the drops in the oxygen, but it was keeping the airway open, then you might be able to get away with a little bit lower pressure, perhaps. But now, what her main question was, the sleepiness is continuing, right? And so if in spite of, bilevel, there is data, right? This last comment here, Pat, that sleepiness is present in myotonic dystrophy, and the cause of it is still unclear. So a number of patients that get on the CPAP and are compliant and use it, they still are very sleepy. Definitely screening for other sleep disorders, medical problems, and then if all of that comes out negative, then considering a daytime test such as an MSLT, the perfect day, 5 naps, might be indicated, and then potentially a trial of alerting medication might be indicated. But before I can definitively say yes, modafinil, we definitely need more randomized, well conducted research to help guide us on that. But I wouldn't discount it. I would keep an open mind about an alerting medication.
So this is going to be the final question.
Yeah.
And somebody writes, my husband is DM1 and is on a non-invasive ventilator due to his diaphragm being affected. He barely made the chart on his pulmonary function tests for the past 4 years. Since he has a tendency to stop breathing at night, he mostly wears it at night. Would it be of any benefit for him to have a sleep study done?
So it depends. So a sleep study wouldn't hurt anything. It would only allow us to his doctors to fine tune the pressure settings for the machine to make sure that his oxygen is staying up, that his brain is staying asleep, that his airway is staying open. So it would allow his physicians to fine tune the pressure settings. Probably what they've done is a home oxygen test, where he just wears a finger probe to check his oxygen, and they've determined that that's fine. So as far as the pressure settings, it might be okay from an oxygen standpoint, but the real question is maybe if he's very sleepy during the day, what's going on with the brain? Because the first response when you're not breathing that well and the airway is closing off and stuff is for the brain to wake up. And so I would say for getting a study can help fine-tune the pressure settings. Most certainly, if he's excessively sleepy and on modafinil, he should really consider getting a sleep study to fine-tune those pressure settings. But talking to a sleep doctor that is a pulmonologist, so a lung doctor that's specialized in sleep medicine, that might be a good option for him or her. For him.
Mm-hmm. Well, thank you so much, Dr. Ruoff. This has been a wonderful webinar, and people had a lot of good comments too. I mean, there were some votes about modafinil and some, passing on words of wisdom, but they were very engaged with your discussion.
Good. I enjoyed it.
Well, thank you everyone for your participation, and I hope you all have a good night's sleep. Thank you.
Take care. Bye.
Bye-bye.